hormones. If you don't mind, I'm going to record it. We're going to talk about, a lot of the controversies and things that that we deal with. Those of us who are in the in the hormone world, we deal with every day. So this is actually a CME lecture. So let's move forward here. And so I have objectives. And objective one is, what is the big hullabaloo about bioidentical hormones in general and bioidentical hormones in particular? Why all the controversy? I mean, you have chemotherapy agents that cause massive destruction of tissues, not a problem. You have cardiovascular drugs that can stop an elephant, not a problem. But when it comes to hormones, all of a sudden, our colleagues are what I call hormonophobic. So we're going to review the position papers of the AMA, the North American Menopause Society, and the American Academy of Clinical Endocrinology. I use that as a starting point because, like the article I just put in the file 13, it's full of what we call now misinformation. We're going to review the scientific evidence, pro and con, in relation to the use of bioidentical hormones. And then I'm going to briefly go over 4 recently released FDA-approved bioidentical hormones. And hopefully you'll get a sense of what can be done and where we're going with this. So it's not going to move forward on its own, I see. Tap it. Okay, so first of all, what are bioidentical hormones? These are plant-based, and they contain the same molecular structure to those that are naturally produced in the body. And understand that they are poorly understood, even by experts. The most prescribed drug in the United States in 2002 was Premarin, synthetic estrogen. And after 2000, after the WHI study, and we're going to discuss that in a little bit, it fell off dramatically. So these are bioidentical hormones. These are the hormones that are naturally made in the body, and that we can have them. We can synthesize them in the in a compounded form. These are non-bioidentical hormones. These are the synthetics, and so here are your your androgens that come from the guys get out of the gym. Here some thyroid hormones, specifically synthroid, synthetic thyroid, levothyroxine, desmopressin, melatonin 2, which is actually a peptide, and all of the others. And here are your birth control pills also. So those are synthetics. The traditional medical community tells us that they know better, and that we're not, what we're doing is illegitimate. It's been declared by folks on our side that bioidentical hormones are safer than conventional hormones. And this Dr. Burnett at the Mayo Clinic, when asked this in a panel discussion, without any alliteration, stated flatly, no, they are not. The Endocrine Society in 2006 and 2009 stated there is little or no scientific evidence to support the claims that bioidentical hormones are safer or more effective than traditional FDA-approved therapies. And they used this study as a justification for that. Patients receiving off-label therapies not backed by scientific evidence are more likely to experience adverse drug reactions. But if you look at the study that they quote as evidence that bioidentical hormones are quote unquote dangerous, they quote this study, which was a 46,000 patient cohort from 151,000 prescribed drug incident from primary care clinics in Quebec, Canada. Off-label use lacking strong scientific evidence had adverse drug reactions at a 3-to-1 time rate of those of FDA-approved drugs. However, off-label use with strong scientific evidence had the same adverse risk reaction as on-label use drugs. And the risk reactions were 5 to 7, were greater when there was 5 to 7 drugs. So this was the study that was determined to be used, that was determined that bioidentical hormones were dangerous. However, in this study, there is not one mention of hormones anywhere. These were cardiovascular drugs and hypertensive drugs. And so to use this study as evidence that bioidentical hormones are dangerous, we got Pinocchio here. I mean, it's a pants on fire, predetermined outcome. It doesn't make any sense. The Mayo Clinic in 2011 stated there was no evidence currently suggesting that bioidentical hormone formulations offered any clinical relevant benefits. And I picked out the Mayo Clinic particularly because we're going to come back to them in a few minutes. The American Association of Clinical Endocrinologists. Women who cannot control their severe vasomotor symptoms, i.e. menopausal symptoms, first lifestyle changes. And as you know, along with statins, we're told with lifestyle and diet first, wink, wink, and then give statins, within the next 30 seconds. The proposed intervention is number one, venlafaxine. I tell my students, if you don't know, if you've never dealt with a venlafaxine withdrawal, it's quite horrendous. It's worse than heroin. It's worse than any narcotic you've ever dealt with. My students prescribe venlafaxine. I tell them right off the bat, they get an F.
Yeah. It's called side effects.
Right. Okay. Mike, you're on here. You know what I'm talking about.
It is Effexor is a very good and strong antidepressant, but it is not a first-line therapy. It's very hard to get off and very hard to get on.
Well, this is the first line. This is the Endocrine Society's first-line therapy.
It's not a first-line drug, man. Yeah.
Well, this is what they recommend. Number 2, clonidine. Number 3, midrestrol, specifically synthetic progesterone, and number 4, gabapentin. I don't do any of this. In 2017, they updated these recommendations somewhat. There were no changes previously, and they still recommended venlafaxine. Transdermal, as compared to oral estrogens, was less likely to produce thrombotic events. Progesterone, when necessary, should be micronized, and that's considered a safer alternative. That is bioidentical. Symptomatic use of bioidentical hormones can be substituted with SSRIs, clonidine, and gabapentin, and bioidentical hormones are not recommended for use. Also out there, we're not really loved, that those of us who do this. So Marie was my nurse, one of my first nurses in the 80s. 30 years later, in 2017, she contacted me that she wasn't feeling well and no one was helping her. We found that she had Hashimoto's thyroiditis, and I hadn't seen her in almost 30 years, and she was menopausal, which was kind of a shock because last time I remembered her, she was about 32 years old. So she then goes. We got her antibodies down. We got her thyroid stabilized. She was doing quite well. She goes to an endocrinologist, and I love this here. I feel Dr. Clearfield is a shaman preying on the placebo effect. In my opinion, it's a shame he is a DO and disgraces the degree. So if not, this is a medical record, by the way. I just photocopied this out. And secondly, we reviewed, there is no, capital N-O, legitimate peer-reviewed literature supporting the use of androgens in women for any reason. N-O. She is only increasing her risk of hirsutism. And those of you who heard my testosterone in women lecture know that I show this also, and I'll show you 135 peer-reviewed articles right after this, but I don't have it in this one here. What else? So I give this talk a lot to what I call our white bread medical physicians and medical personnel. Those who are don't think like us and would never dream of joining Dr. Halas's group or our group. And I always ask them this. I ask them, who never strays from the FDA's orthodoxy? Who never prescribes anything off-label? And invariably, about 50% of the hands go up. And so I said, just for fun, let's take a trip down memory lane. Those of us who've been around a while remember Vioxx. Vioxx, remember, was released in 1999. It was a COX-2 inhibitor. It was supposed to protect the GI tract from the erosions that you get from the COX-1 inhibitors. Unfortunately for Merck, they decided that they were going to look for a colon cancer indication. And so they had to do longer term studies, which revealed 140,000 incidents of premature coronary artery disease. And it was unceremoniously taken off the market 5 years later. $6 billion worth of litigation related expenses occurred. They were making $3 billion a year in profits off of Vioxx for the 5 years that it was available, but that just wasn't good enough for them. FDA approved. Number two, Baycol. Baycol was a statin. It was recalled in 2001 after 4 years due to 100,000 deaths due to rhabdomyolysis. And of course, our favorite, OxyContin. Highly addictive, easily accommodated. Patients need larger and larger doses to achieve relief. It was the leading drug of abuse from 2004 on, and there have been 29,000 drug-related fatalities, I think annually now, due to overdose. Premature death cost is $63 billion, and the average life year lost is 29 years off of a patient's life. In 2015, they were fined $600 million. The family that owned the company, Purdue, was on the Forbes richest list, and the FDA approved OxyContin for children as young as 11 in 2015. Since that time, things haven't gone so well for them. They filed for bankruptcy in 2019, and I think there's still ongoing litigation. But again, these are all FDA approved. Remember, these are the things that we're supposed to, have confidence in. Risperidone was approved for autistic children for irritability and outbursts. Its side effect in risperidone is elevated prolactin, which was well known, but the manufacturer stated that the elevated prolactin levels in boys and gynecomastia and other side-related effects were related to excess prolactin, didn't happen at the doses that they used. The FDA approved it in 2006, and it didn't take long for extreme weight gain and gynecomastia to develop in a lot of young males. And if you know about autism, you know it's a 4-to-1 ratio males to females. The company paid a $2.2 billion fine, and it turned out that the data tables showing the correlation between prolactin and gynecomastia were hidden during the approval process. These are the 10 most common off-label use drugs in the United States. And this is, I ask a show of hands, who would never use off-label drugs? And usually by the time we get down to here, there's not a hand up. The physicians don't even know they're prescribing off-label. So SSRIs for hot flashes, tinnitus, premature ejaculation, amitriptyline for headaches is not FDA approved, fibromyalgia, statins for rheumatoid arthritis, clonidine for smoking cessation. And here you go, hot flashes. This is what the Endocrine Society said we were supposed to use as first line, or this is second line. Abilify for dementia, gabapentin for peripheral edema, especially in diabetes and migraine headaches, topiramate for bipolar disorder and depression. There's a combination topiramate and phentermine drug now, so I should take that one out. Risperidone for Alzheimer's disease and dementia, trazodone for insomnia, and propranolol for stage fright. These are all off-label, and I'm sure most of the physicians here have probably prescribed these at one time or another. And so this was the 2009 position paper of the AMA, stating, quote, there was no credible evidence that exists on the value of bioidentical hormones. And they had these 7 talking points. 1 and 2 dealt with testosterone. Current evidence did not support the use of testosterone in older men with low testosterone levels, and the evidence of value of testosterone as an anti-aging therapy did not exist. Number 3, current evidence failed to support the use of growth hormone as an anti-aging therapy. Number 4, the long-term use of estrogens with or without progestins, and that's not progesterone, progestins, causes more risks than benefits. The long-term use of estrogen for the prevention of chronic conditions in postmenopausal women is not recommended. DHEA as an anti-aging supplement showed neither meaningful benefit nor serious adverse effects, and there was no evidence of long-term changes in the therapeutic doses of, quote, anti-aging hormones. In 2016, they updated this. Number one, they supported clinical decision-making authority of the physician. So that's kind of how they wrangled out of, they didn't like the compounded bioidentical hormones. Number two, the use of compounded hormone therapies is not supported by evidence still. Number three, the traditional compounding is recognized as legal and important therapeutic approach when an FDA-approved drug is not available or does not meet the clinical needs of the patient. However, in many cases, the use of compounded hormones, comparable therapies are available, and further concern is prompted by the fact that compounding pharmacies are exempt from including specific and important safety information on label instructions. So I urge you, if you use a compounding pharmacy, Mike, you know more about this than I. PCCA has standards that are pretty close to the, or even superior to the FDA recommendations.
Mm-hmm. Absolutely.
Okay. We like to use the Ed Begley Jr. rules. If you don't know who Ed Begley Jr. was, he played a doctor in a silly TV show in the late 80s called St. Elsewhere. He became an environmental activist. He was on a late night TV show one night, and he was talking about climate change and whatever. I'm not going to get into one way or the other, but his message was, don't get your information from him or anybody or any newscaster. Get it from the people with the PhDs after their names. So we're going to do that for bioidentical hormone. We're going to see what the people with the PhDs or the MDs and the DOs have to say. So a quick Google search. Remember the ANA says there was no evidence of efficacy of bioidentical hormones for anything. The use of compounded therapies was not supported by evidence. In a quick search, I found, it took me all of 15 seconds to find this study here. It was done at the University of Kansas. It was over 12 years. Bioidentical natural hormone evaluation in early menopause. And it had 4 arms. One was synthetic, and the other 3 were different varying doses of bioidentical hormones. And the outcomes, I won't go into the details, showed that endometrial thickness and cholesterol levels were pretty much across the board the same, except for 2.5 milligrams of estradiol and 100 milligrams of progesterone. And the endometrial thickness in the synthetic arm was the greatest, and in the bioidentical arms were much less. And in the mammograms, bone density and adverse reactions, it was essentially 0. And so this took all of 15 seconds, to look for. So if you don't want to look for it, you're not going to find it. In 2018, the FDA approved the bioidentical capsule. And again, remember, this is a CME credit lecture, so I don't have the name of it, but I can mention it here, right? It's okay? Anybody?
Go for it. Go for it.
Yes,
Yeah.
Bill, it's
Okay.
fine.
Please.
All right, so this is called Bijuva, Bijuva, and is an estradiol progesterone capsule that has been reformulated. It's not just estradiol and progesterone put together, but it's been reformulated for the treatment of moderate to severe symptoms, vasomotor symptoms due to menopause. It's a brand name, and it was the first, and I think it's still the only FDA-approved hormone therapy of bioidentical estradiol in combination with bioidentical progesterone. And it comes in 2 fixed doses, 0.5 milligrams and 1 milligram of estradiol and 100 milligrams of progesterone. But even this is poorly understood. If you go to WebMD and type in Bijuva, this is what you'll find. This medication contains 2 female hormones and estrogens, such as conjugated estrogen, which is synthetic, which it is not, and a progestin, such as medroxyprogesterone, which it is not. It was made specifically not to be these things, but there it is. Women who've had their, I like this one too. Did we talk about this? Women who've had their uterus removed do not need the progestin and therefore should not use this combination medication. Did I give that lecture to you guys yet? Progesterone after hysterectomy, yay or nay?
No, I think it's the first time here.
Okay. All right. So I have a lecture on that also. Current evidence. So these are the first 2 talking points for the AMA. versus testosterone. Current evidence does not support the use of testosterone in older men with low testosterone levels, and the evidence of the value of testosterone as an anti-aging therapy does not exist. Here are the benefits of testosterone. It's an antidepressant. It's an anti-anxiety agent. We end up with a greater sense of well-being. It will increase muscle mass, strength, energy, exercise tolerance, memory, skin turgor. It elevates brain norepinephrine. It increases sexual interest and sexual performance. So it's much more than just an increase in libido. It will decrease body fat, maintain bone strength. It reduces LDL cholesterol. It is protective against bone loss. It improves insulin sensitivity. It protects against diabetes. In fact, the testosterone levels and the incidence of diabetes are inversely related to each other. It's involved in the making of proteins and muscle formation. It increases oxygen uptake throughout the body. It regulates acute HP axis responses when challenged, and it is necessary for sperm development. Remember the talking point, no consistent relationship has been shown to proven between testosterone levels and symptoms associated with low testosterone. But let's look at what the people with the PhDs have to say. Men with coronary artery disease have significantly low total testosterone, free testosterone, and bioavailable testosterone. Low endogenous testosterone concentrations are related to mortality due to cardiovascular and other causes. And men with coronary artery disease under the age of 45 have total and free testosterone levels significantly lower than controls. So again, no consistent relationship has been proven between testosterone levels and symptoms associated with low testosterone. I believe you can see just right here, that's not true. Carotid artery disease. Serum testosterone levels are found to be inversely related to carotid intimal thickness. Low testosterone levels are associated with atherosclerosis in men. Endpoint, prevalence of concomitant cardiometabolic conditions when testosterone levels are consistently below 300. Obesity is 2.4 times the incidence of when testosterone levels are low versus adequate. Type 2 diabetes, twice as prevalent. Hypertension, 1.84 times as prevalent. Hyperlipidemia, 1.5 times as prevalent. Asthma and COPD, 1.4 times as prevalent. And prostate disease, 1.3 times is prevalent. Now, wait a minute. I thought testosterone caused prostate disease, right? Weren't we taught that? Didn't we do that? We did that last week, right?
We did.
We did that last week, right? You guys
You're interfering with the sales of pharmaceutical drugs here.
Okay. Testosterone and heart disease. Low testosterone levels are associated with increased mortality, atherosclerosis, and incidence of coronary artery disease. Mortality is reduced by 1/2 in testosterone deficient men when they are treated with testosterone therapy adequately. Thanksgiving 2013, this came out. Don't ask your doctor about low T. The study came out from the VA in Boulder, Colorado, linking testosterone to heart attacks. And the FDA was evaluating the risk of stroke and heart attack and death with FDA-approved testosterone products. Now notice, FDA-approved testosterone products are different than bioidentical testosterone products. Let's move ahead here.
That's because they have intellectual property attached.
Yeah, well, they have to alter the compound so it's their own unique it's their own unique drug. This study stated the risk of non-fatal MI was greater in the 3 months after the beginning of testosterone therapy. And it was a big hullabaloo about this because we've already been working with testosterone for 20 years. And those of us who've been working with it just never saw this. In fact, it was quite the opposite. It was an ICD-9 study that was what was around back then. No patients were ever seen. There was no information on the preparation, doses, or intervals of usage. There was no information on fatal MIs or cardiovascular mortality. And there was no information on the testosterone serum levels before or after therapy. This was their information that they presented. The gray were the patients that were not treated. The darker bars are the patients that were treated. And if you look across the board, and over here is all events, the patients that were treated with testosterone had half the events of those that were treated, that were untreated. And yet it was reported the exact opposite. And Abraham Morgenthaler called them out on it in this paper here. And where was it? Remember what the Mayo Clinic said about bioidentical hormones? No bueno, right? Well, here it is. The Mayo Clinic published this, where he pointed out that they reported the exact opposite of what they found. And so, again, if you want, you can probably come to a predetermined outcome and then try and fit it in. So I'm kind of getting away from this. I thought it was funny. I gave this talk during the campaign in 2020. I thought it was funny, but now it doesn't seem to be so amusing anymore. Also, there were 1,132 men excluded from the analysis that didn't fit into their criteria, which was that to make it look like that the outcomes that they wanted, it didn't fit. There was an 89% considered error rate. There were 100 women actually identified in the studies. 1 out of the 11 men were actually women. There were over 160 leading testosterone researchers and medical societies called for the retraction of the study. It was later sort of mealy-mouthed, reworded, but it was never retracted, and it'll still pop up if you put in testosterone and heart disease. But it's been determined by most legitimate medical societies and testosterone researchers as not legitimate. Testosterone and depression. Testosterone is an antidepressant effect, especially those with hypogonadism. And testosterone and growth hormone improve body composition and muscle performance in older men. And you can measure this to a fairly accurate degree. Men with free testosterone levels of 295 nanograms per deciliter or a free of 6.0 nanograms per deciliter are at risk for frank depression. And at 147.5 and 3.0, nearly 100% of them will have major depression. For women, it's 22 and 1.0 that are risk, and depression at 11 and 0.5. And so those of you, again, those out in the real medical world who are pushing SSRIs and then atypical SSRIs, and then we add Abilify and then we add this drug and add that drug, a simple check of testosterone will invariably find, we see this a lot, especially in women, at least in my area. We see a large number of women with very low testosterone levels. And, we get them up to an adequate level, and our adequate level there total is 30 to 40 and a free of about 2 to 4%, 2.0 to 4.0. And right here, and they're doing much better. Testosterone also will moderate anorexia nervosa. Testosterone.
Well, let me add something here. If they are concerned about serotonin, I think we have an answer for that. McCarran Blvd does help to increase the serotonin. Mm-hmm. So with your sex hormone and McCarran Blvd, which actually helps to negate any side effects of sex hormone if there's any, I think it's the safest way to go. Just if those people are concerned about serotonin, there's better, cheaper way of increasing it with almost no side effects.
Okay, thank you. All right, traumatic brain injury. We see a lot of patients with traumatic brain injury here, and down the road, 3 months later, 10 months later, a year later, 5 years later, and when they have, especially when they have severe personality changes, depression is the number 2 symptom of secondary to even mild traumatic brain injury, and about 77% of patients will have some form of new onset depression from traumatic brain injury, and nearly 100% will have chronic fatigue. And this is our suicide population. It's the TBI is the 10th leading cause of death, or suicide is the 10th leading cause of death in the US. There's a direct relationship between depression and suicide, and there's a direct relationship between depression and low testosterone. Men have 4 times the suicide risk of women, and the suicide attempts are inversely related to testosterone levels. This last line here, I got this from a Dr. Davidson, who is the chief at psychiatry at UCSF. It was in a lecture. He stated that the peak years for men for suicide were 80 to 90, which was kind of a surprise to me, and from women from 50 to 65. And he stated he attributed it to the loss of estrogen. So I was in the audience. I was actually going to give a lecture on estrogen. I was the next person up. And so I kind of held myself until it was my turn. And I turned around my beginning and I said, well, why don't you give these women estrogen then, if that's the cause? And his initial reaction was, one, we don't know how. And then 2, he said, we can't. This was in 2015. We saw him last summer. Again, I hadn't seen him in a long time. And he came up to me and says, well, we're referring our women, our depressed women now in this age group to the gynecologist. But you're going to find that gynecologists are, for the most part, are they know how to do birth control pills, but and give Premarin, but that's about it. And testosterone, forget about it. And natural progesterone, forget about that also. Testosterone and anxiety. Testosterone reduces anxiety and enhances cognition. It is analgesic and anxiolytic and has cognitive effects are due to the action of 5-alpha reductase metabolites in the hippocampus. And just as an aside, we check prolactin levels in every patient. Low prolactin levels, less than 6.0, is a tip-off to chronic treatment-resistant anxiety and depression. Low testosterone levels is predictive of hypertension, and it's a biomarker for increased cardiovascular risk and mortality in congestive heart failure. Total sex hormone binding globulin. When you go from the lowest to the highest percentiles, you get a 62% decrease in carotid intimal thickness for total sex hormone binding globulin, and we go from the lowest to the highest quartiles. For total testosterone, we get a 52% decrease in carotid intimal thickness. Our studies tell us that there's not been yet found any correlation between atherosclerosis, estrone, DHEA, sulfated, or androstenedione. Urinary incontinence, 6 to 12 weeks to months of testosterone, 0.5% ointment topically around the urethra and labial opening will decrease stress incontinence in 85 to 99% of patients. In uresis, I'm not sure who would do this study, but testosterone propionate, 10 milligrams. This is short-acting testosterone. It only lasts about 36 hours. In 3-year-olds to 14-year-olds, we get a 80% improvement in cured in boys and a 93% improvement in girls. I'm not so sure I would do that, but again, here's a study. This is an important one because you're going to hear this. One of the reasons in fact, our advanced lectures are that patients come in and they'll say, and you've heard this, my doctor said, you gave me testosterone and it's going to cause X, fill in the blank. Breast cancer. I've heard this over and over again. Breast cancer incidence in 100,000 year women years, 390 in the control, 142 in the treatment group. 2/3 less incidence of breast cancer with adequate testosterone levels. This is a comparison of different studies. This is your WHI study where they used the synthetic estrogen, synthetic progesterone. Breast cancer incidence was 521 per 100,000 women years. No hormones, 283, and testosterone only. So patients with women with testosterone had less breast cancer than if we gave them nothing at all. Oral versus estrogens versus oral estrogen testosterone showed an improvement in body strength, in a reduction in weight, and reduction in fat mass, and a change in lean body mass. Alzheimer's disease and dementia. Dementia's tremors and gait dysfunctions were attributed to low testosterone. Low testosterone equals memory loss. Behavior. Testosterone downregulates allopregnanolone. Allopregnanolone generates GABA, your calming neurotransmitter, which this is where we get our irritability, your road rage, your impulsive aggression, and signs of major depression. When we get a diminution of allopregnanolone. Just as an aside, the benzodiazepines stimulate allopregnanolone to make GABA. And so this is sort of the opposite of that. Our remedy for this is actually a high dose for a short period of time at 2 to 4 weeks, 400 milligrams of pregnenolone will drive your body to make progesterone, which will then convert to allopregnanolone. Dementia, tremors, and gait dysfunctions are attributed to low testosterone. Memory is attributed to adequate testosterone. Age-related decline in free testosterone predicts decline in visual and verbal memory. Low bioavailable testosterone is a positive indicator of memory loss. You get the idea here. Free and total testosterone, for every 10 nanogram nanomole increase in free testosterone, there's a 26% decrease in risk of Alzheimer's disease. And so we can substantially decrease the risk of Alzheimer's disease when our patients are have adequate testosterone levels. Serum testosterone levels with reference ranges that are normal, quote unquote normal, have decreased vigor, libido, depression, type 2 diabetes, and erectile dysfunction. So if you look at depending on which lab you're looking at, and serum levels for one of the major labs here is 264 to 916. But we start seeing libido issues at 430, which is about midpoint. And then depression, as we talked about before, and diabetes starting at 295 actually, or 288. And erectile dysfunction is almost 100% at 231. Women need testosterone a little bit. Guys need estrogen a little bit. And it has pretty much the same function. It decreases visceral fat deposition. It will decrease cellulite, wrinkles. It is an antidepressant. It is useful for mental fatigue, vaginal dryness, moodiness, irritability. It will decrease LDL cholesterol, and it will decrease sore body syndrome. It will decrease weight, fat, abdominal fat, gluteal fat, and total body fat, and BMI. Some novel uses for testosterone: dry eye disease. We can compound a 0.3% testosterone and 0.5% progesterone and a cyclodextrin base for dry eye syndrome, and this works quite nicely. We've done this in a handful of cases. Chronic pain and fibromyalgia. Patients will come in and tell me that their backs don't hurt, their knees don't hurt nearly as much or at all anymore. Chronic non-radicular low back pain. Testosterone, we covered this last week, and we know that there's no relationship now we've discovered between testosterone, DHT, and estradiol. So I'm not going to belabor this point. I showed you this study last week. And increase, this one is very interesting. Adequate testosterone levels, remember, we like 700 to 900. Men that have testosterone levels greater than 600 live on average 10 to 15 years longer than men who have insufficient testosterone levels. No credible evidence exists for the value of bioidentical hormones. We're now going to talk about growth hormone. Do you want me to go? There's 20 chats in there. Is there something there for me to answer? Or should I?
No, go ahead. And then at the end, we can go to the chats. Okay. We don't want to lose the stuff.
Okay. So Rudman in 1991 in the New England Journal of Medicine published this study where he found that with adequate growth hormone levels, and they used high doses, and their endpoint was an IGF-1 of greater than 300, which is kind of a high dose. We usually try to get our patients to 200. That seems to be adequate. He found an 8.8% increase in lean body mass, a 14% decrease in adipose tissue, a 1.5% increase in lumbar vertebral bone, and skin thickness was increased by 7%. Growth hormone deficiency was only seen in patients with severe multiple deficiencies since childhood. That was the going talking points. Patients treated with growth hormone experienced significant improvements in concentration, memory, depression, anxiety, and fatigue. Pituitary failure can only occur even in minor head injuries and is poorly recognized. And adult growth hormone deficiency is often common and often not recognized after traumatic brain injuries and brain insults. You will see a drop in growth hormone and testosterone in 70 to 80% of patients with traumatic brain injury within 96 hours of the injury. Growth hormone replacement improves cognition, quality of life, and especially in those with severe disabilities. I'm not going to go through all this, but here are the benefits of growth hormone.
So let me add something. When you have brain injury and you have low testosterone, do you think it's better to give central activated hormones, sex hormones like clomiphene and HCG for those people? What do you think?
It depends. It depends on the age group. Age under 40, I never give men testosterone for a variety of reasons. So we would use the central acting agents like you had. We will use growth hormone in low levels. Usually we start with the peptides, however, if they because a lot of the mild head injuries that respond to the peptides drive your body to make growth hormone rather than coming in like the blob and shutting everything down. So growth hormone deals with a lot like testosterone: strength, energy, sense of well-being, mental clarity, memory, but also things like what's known as executive function, concentration, memory, being able to start projects, being able to finish projects, being able to multitask easily. Those with low growth hormone have obsessive compulsive tendencies, paranoias, dark moods, and suicide ideation. Remember, IGF-1 is the downstream usable portion of a growth hormone. It's insulin growth factor 1. It's similar to insulin. And what you'll find is with adequate IGF-1, increased cognitive function, increased response to hypoglycemia, better fertility, better thermogenesis, better brain development, decrease in appetite, decrease in hepatic glucose output, and decrease in blood pressure. There's a disconnect in autistic children between growth hormone and IGF-1. IGF-1, again, is the usable portion. Growth hormone is not, itself does not affect the body. It has to be converted in the liver to IGF-1, and there's a disconnect. One of the first signs of autism is an extremely large head, and some parents will find this at ages 1 to 3 months even. With measurements find that these babies have high growth hormone levels but low IGF-1 levels. And I think we talked a little bit about this, Dr. Halasso. The culprit is interleukin-6, which is generated by the growth hormone, but interferes with the growth hormone insulin growth factor pathway. Growth hormone reverses early atherosclerotic changes. It decreases in oxidative stress by 50%, and it increases thyroid and androgen functions, but it decreases cortisol. So here are your interactions. Growth hormone will increase thyroid function. It will increase testosterone, but it decreases cortisol. IGF-1, which is again the usable portion of growth hormone, is inversely related to weight. The highest quartiles of insulin growth factor 1 show decreased abdominal fat. That's what they're showing you here: abdominal fat and BMI. Atherosclerosis. Growth hormone deficient patients showed a 9-fold increase in cardiovascular mortality. And in tumor growth, also tumor node metastasis, the higher the growth hormone levels, the lower the metastasis. Now, again, this flies in the face of conventional reality, which tells us that growth hormone feeds tumors and makes them worse. Well, here again, here's our studies that show us that that's not true. Growth hormone is directly related to thyroid activity. And all mortality with growth hormone use post-MI is decreased by up to 300%. This is a study of 3 years post-MI, women that had adequate adequate growth hormone level, had 0 mortality, and those who had no growth hormone supplementation had a 4.5-fold increase in mortality. In men, it wasn't quite as good. It was about 1 to 3, and all mortality showed that 0.84 patients had mortality versus 3.8 times the incidence with no growth hormone. Growth hormone deficiency is only seen in patients with severe multiple pituitary deficiency since childhood. Some degree of hypopituitarism is found in 35 to 40% of traumatic brain injury patients. So this isn't true. Untreated traumatic brain injury, TBI-induced hypopituitarism, contributes to the chronic neurobehavioral problems seen in many head injury patients. Traumatic brain injury and growth hormone deficiency, I already went over this, results in memory, losses of memory, concentration, mental clarity, dark moods, paranoias, obsessive compulsive tendencies, anxieties, and poor concentration. Rapid weight gain, excessive anxiety, depression, poor overall physical health. And the key here, especially when we were talking about our autistic patients, and the key here is what's known as executive function. These are cognitive and mental abilities to achieve goals, and these are lost with growth hormone deficiency. This was our aha moment. Growth hormone abnormalities, executive function is the one possessing the cognitive and mental capacities to achieve one's goals. This is a hallmark of growth hormone deficiency. You find a patient that is doing poorly in mental clarity, memory, concentration, being able to start projects, being able to finish projects, being able to multitask easily. They may have obsessive compulsive tendencies, dark moods, paranoias, and they don't have to have all of these, but a good number of them. I want you to think about growth hormone deficiencies. The long-term use of estrogens with or without progestins causes more risks than benefits, and the long-term use of estrogen for the prevention of chronic conditions in postmenopausal women was not recommended. So estrogen has 400 functions. It affects your mood, energy, neurotransmitters, memory, cognition, reasoning. It is an antipsychotic agent, and it protects against neurons in traumatic brain injuries. It protects against bone loss, skin thickness, and insulin sensitivity. And those of you, my early career, I saw a lot of nursing home patients, and you could go into the dining hall at any nursing home, and you see the elderly women there, those who had nice, smooth, shiny cheeks, and versus those that had wrinkled faces, you can be reasonably well assured that the ones with the shiny cheeks had some sort of hormones. Probably back then they were synthetic, but they had some sort of hormones. Also libido, sexual performance, a metabolic rate, artery size, and it affects blood flow to the brain and HDL cholesterol. Estrogen decreases carotid artery plaques, coronary artery disease by 40 to 50%, homocysteine and blood pressure. It protects against vaginal dryness, sexual dysmorphia, tooth loss, colon cancer, wrinkles, depression, anxiety, irritability, and Alzheimer's disease, and the risk of PTSD. And you know that there are creams available for vaginal dryness. So how they can on one hand say that there's no evidence for estrogen for use of anything, and vaginal dryness, bone loss. I mean, these are all well-known functions of estrogen. Symptoms of low estrogen or irregular or missed periods, hot flashes, night sweats, mood swings, belly fat, and loss of memory, also loss of libido. And then, of course, there's the elephant in the room. Estrogen causes cancer, right? So those of you who do not know, if you've not seen this from me before, this was Lucy the elephant. I'm from the East Coast. We would go to Atlantic City, in the summertime, this time of the year. Lucy the elephant was built in 1881 as a hotel. It was restored in 1975 and moved down the beach into Margate, New Jersey, which is three beach towns down from Atlantic City. It is now the Museum of South Jersey. The eyes are looking at the Atlantic Ocean, which we're over here on the right. The back end is looking at the town of Margate, New Jersey. And the museum is here. You can go up in here and it's called the How Do and look all around. So according to the AMA, like the Ghostbusters, you're crossing the streams and it's very, very bad. The WHI study found that hormone replacement therapy was dangerous. Premarin alone given to older postmenopausal women caused adverse reactions in the first year, including blood clots and strokes. Oral estrogens caused blood clots. Transdermal estradiol did not. Adding Provera, synthetic progesterone, either separately or as Prempro, caused more adverse effects, breast cancers, heart attacks, and dementia. Provera increased breast cancer and vascular inflammation. Progesterone did not. In the literature, it's going to say progestins. Progestins are synthetic progesterone. They are not progesterone. And here is a schematic for Premarin. Here's estrone, which is natural. And here is Premarin, which is not. And you can see, you don't have to be a biochemist to see that these are not the same. This is a drug. This is a hormone. In the equine estrogens that contain at least 10 estrogen molecules, usually only 3 of them are human. The rest are all from mare urine. The killers of women are cardiovascular disease, osteoporosis, dementia, and breast cancer. They are all pretty rare before menopause. The first 3 are clearly related to estradiol deficiency. Breast cancer actually is related more to progesterone deficiency. We'll look at that in just a minute. Early removal of ovaries increases the risk of heart disease, osteoporosis, and dementia. And I was an OBGYN resident. You may have heard me say this before. We would do our hysterectomies. We would tell our patients, here's some Premarin that'll keep you away from having hot flashes. And oh, by the way, you don't need progesterone because you don't have a uterus anymore, so you don't have to worry about that. That was wrong and wrong on many levels. Estradiol protects against heart disease, dementia, and osteoporosis. It improves insulin sensitivity. It eliminates hot flashes. It restores sleep. It restores cognitive function and maintains thickness of the skin. It maintains genital and pelvic health, and it protects against colon and cancer and macular degeneration. It prevents the oxidation of LDL cholesterol. It improves the lipid profile. It reduces blood pressure, improves endothelial function. It reduces plaque formation and improves insulin sensitivity. Estradiol replacement increases the risk of blood clots. Oral estradiol does. Transdermal does not. The FDA-approved estradiol progesterone pill by Juva does not alter coagulation factors. And this is—
Hey, Bill, if you don't mind me stopping you there, why is the oral estradiol prone to causing problems where the transdermal is not? What's the distinction?
Because
You have
it has to get conjugated through the liver.
Gotcha.
Got it? Okay.
Yeah. So with the liver metabolism aspect of it is problematic.
It is problematic. Yes.
Dr. Bill, where would that leave pellets then in that comparison?
Pellets are equivalent to transdermal.
Great.
We do. I've been doing pellets for 20 years. I can't think of one patient that's had a blood clot. Not one.
Yeah.
Okay.
Yeah.
Cardioprotective, decreased risks of acute MIs, decreased risks of type 2 diabetes. So internal artery lumen widens by 224% when the patient is administered estradiol for greater than 6 months. And this is what the same reason when we used to give men estrogen blockers to get their estrogens down to 0, we ended up with a lot of memory issues and dementias from that. These are the studies, the clotting studies from the Bijuva, the company, and basically showing you that the placebo, which is in gray, is the clotting factors don't change, which they do in most oral estrogens. And again, I showed you early on, sometimes you can't believe them, but this is what we have. Sometimes they're found to not be true. This one I don't know. But so we'll have to take their word for it until proven otherwise. I do know that our patients with Bijuva have way more side effects and discontinue it versus the bioidentical compounded transdermal hormones, and even more than an estradiol patch and progesterone pill. Alzheimer's disease is again, estrogen is protective of it. This was the steroidogenic pathway, how the hormones are generated, and this would be the lecture that I would give to talk about how the hormones interact with each other. What happens if we increase the testosterone? What happens if we give you a drug that blocks 5-alpha reductase and blocks DHT? What happens to the rest of the body? How about pre-hormones? DHT and progesterone. These are pre-hormones. So, your steroidogenic pathway, again, this takes place in the liver. Cholesterol converts to pregnenolone, which converts to DHEA, rather, sorry, not DHT, DHEA and pregnenolone. These are your precursor hormones. And we'll use those as building blocks to increase estrogen and testosterone and cortisol levels if necessary. DHEA regulates estrogen and testosterone. It plays a role in bone health and mood disorders. As early as 1952, it was identified as an antidepressant. It helps prevent diabetes and it facilitates weight loss. I will caution you though, one of the things that we found is that DHEA, seems to be a negative feedback with adequate testosterone levels, and when the testosterone levels are adequate for more than a year, the DHE levels tend to drop, and if you try to bring them up to an adequate DHEA level, they drop even more. So usually after about a year, we discontinue the DHEA. It doesn't seem to be, as long as the testosterone levels are adequate, there doesn't seem to be any point to using them. Pregnenolone is the hormone of memory, and we've used this quite successfully in improving patients' memory. We measure this on every patient at least once, and if the hormone level at the pregnenolone levels are low, we will actually treat the patients. We'll start usually at 30 milligrams twice a day. You can go up to 100 milligrams total, and we'll follow them along. It takes 6 months to a year before you're going to get any type of effect, though. You have to let the patients know that this is not an instant gratification. Prolactin is the milk letdown hormone, also has 400 functions in the body. High levels are indicative of a pituitary adenoma. Low levels are indicative of treatment-resistant anxiety and depression. Hormonal influence on breast cancer risks are due to estrogen excess, oxidation of estradiol and estrone, and the lack of clearance. Estrogen dominance results in allergies, autoimmune issues, and cysts, all sorts of cysts, fibrocystic breast disease, breast cysts, breast cancer, ovarian cancer, uterine cysts, which we call fibroids, uterine cancers, endometriosis, and high estrogen levels will result in gallstones. And a lot of times patients will come in and say, are estrogen dominant pretty much their whole life. I have a tendency to blame birth control pills, especially young ladies who start taking them in their teens, late teens even, or early 20s. By the time they get to their mid-30s, they've been estrogen dominant for a long time. Gallstones are a result of high estrogen. And you will find, remember back in the day, they taught us fair, fat, fertile, and 40 are the gallbladder patients. Well, they kind of missed the boat. It's hormonal abnormality causes the gallstones. And you can ask patients about, again, part of the credibility is if they have an estrogen dominant pattern. Most of our patients, we have the lab work. We get it done before we see them because we're so swamped. We can't. It would be months between seeing them and then bringing them back for their blood work. So we have it done beforehand when they make their first appointment. So we have it in front of us, and I'll look at them and I say, any gallbladder problems? Oh yeah, I had my gallbladder out when I was 30. Also, with a mammogram, did you have a mammogram? Let me tell you what it shows. You had dense breasts. Yes. How did you know? Estrogen dominance. So when you start recognizing these patterns, you're going to build your credibility. Progesterone is the only effective treatment for estrogen dominance. And again, progesterone versus progestins. Here's progesterone on the left, and here are the progestins. And again, they're not the same. I think this is a birth control pill that you only get 4 periods a year or something. And, you know, the young ladies like that, but, you know, it leads to problems down the road. And remember, in the literature, progesterone and progestins are often confused. They're not distinct. They don't distinguish between them. Progesterone is our natural bioidentical progesterone. Our progestins are the synthetics. Progesterone maintains pregnancy, improves mood, improves sleep, has no effect on blood sugar, improves lipid profile, it reduces estrogenic stimulation of the breasts, and prevents breast cancer. The synthetics do the opposite. It causes breast cancer, it causes heart attacks, it worsens the lipid profile, it counteracts the estrogen-induced arterial dilatations, it raises blood sugars, it causes insomnia, and can cause depression. This is kind of a bold statement, but I kind of like it. Who needs progesterone supplementation? Right down at the bottom, every woman in menopause. I'm sure you'll have some arguments about that, but you'd be hard pressed to find any female in menopause that would not benefit somewhat from even modest levels of progesterone. Endometriosis and adenomyosis patients, fibrocystic breast disease, heavy bleeding, irregular menses, no menses, and this you'll see in your polycystic ovary patients.
Can we just make sure that we understand the progesterone and progestin chemically they're a little bit different, but also functionally, can we say for sure
right
that progesterone, progesterone can be recycled more easily than progestin synthetic? Is
Right.
that the reason why, you think?
Yes, absolutely.
Okay.
Okay. I got 35 chats. It's something going on there. Novel uses for progesterone. There have been studies done looking at traumatic brain injury, cerebrovascular accidents, diabetes and mellitus, and blood pressures. There was a phase 2 traumatic brain injury, which using 8 milligrams per kilogram of progesterone IV within 24 hours of traumatic brain injury, which showed great promise. The phase 3 trial was a failure, however. However, if you read the study on the phase 3 trial, they only used 4 milligrams per kilogram. And so you really need to read into these things because, if you want a preordained outcome, you can probably find it. It's not unlike the ivermectin studies that came out 2 or 3 months ago that said ivermectin was, didn't show efficacy for anything. But if you looked at it, they used half the dose that we use, and they only treated them for 3 days. So, it's like using, if you have a strep throat, I'm going to give you 1 penicillin pill a day. And then when it doesn't work, I'm going to say it doesn't work. I mean, exactly same thing. Progesterone inhibited ischemic brain injury. It reduced infarct volume and improved functional deficits following cerebral ischemic events. Now, I don't do hospital work, and I don't usually see these patients until, they're long past their event. But I do try to pass this on to my hospital-based colleagues.
Bill, would that apply to male and female patients equally?
Yeah. Yes, absolutely. Absolutely. Does estrogen cause breast cancer? And the Endocrine Society put this out and reiterated it many times. There was no medical or scientific evidence to suggest the idea that the adverse or beneficial effects found in the world Women's Health Initiative resulted from the molecular structure of the synthesized hormones, nor is there any sound scientific evidence to show that a different or customized dose of hormones would have changed the outcome. Well, I think we've showed you that that's not true also. So here's a trick question. What's the largest study ever done for women and breast cancer? And what did it show? And if you said that Women's Health Initiative, you would be wrong. The E3N study was a European study. Remember, the Women's Health Initiative that did not use any bioidentical hormones. The E3N study did. And what they found was this. This line here, this is baseline, showed no hormone replacement therapy. Patients on synthetic estrogen, which is here, showed on average a 20% increased incidence of breast cancer. Patients on synthetic estrogen and synthetic progestins showed on average 40% increase in breast cancer. And those that were on natural estrogen, natural progesterone, showed a 10% decrease from patients who did not get any hormone therapy at all, 50% decrease from those who had the synthetic progestin and estrogen, and a 30% decrease for those who were just on the synthetic estrogens. And this was 55,000 women over 8 years. So this was a pretty substantial group, and this was pretty specific. It was published in 2005 and again in 2007. And so when your colleagues, your patients come in and they tell you, my doctor said that it doesn't matter what kind of progesterone you use, they all cause cancer. Here's your evidence that that is not true. This is pretty much the same thing. Now, look at this one. 11 years post breast cancer, treating patients with bioidentical estradiol. 11.6 years post breast cancer, 33% of the patients who had no hormone therapy were dead. Those who had estradiol, testosterone, and progesterone therapy, there was a 94% survival rate here. Here, there was a 67% survival rate. And those that were given an estrogen blocker, testosterone, and progesterone had an 87% survival rate. This is pretty substantial evidence that the natural bioidentical hormones have a great effect on a patient longevity and mortality. And believe it or not, this was in the Green Journal when I was an OBGYN. This is one of the journals we read all the time. And this was in 1999, so this isn't anything new. Adequate progesterone levels protects against breast cancer. When the progesterone levels are at 9 nanograms per milliliter, we get a 60% decrease in breast cancer. When it gets up to 13, we get an 88% decrease in breast cancer. Now, admittedly, you'd have to use a lot of progesterone to get to these levels. But the point is that when we have adequate progesterone levels, the patients have much less breast cancer. In my practice, I've been doing bioidentical hormones for almost 20 years now. We have had 2 patients in our 20-year history with breast cancer taking bioidentical hormones. And those of you who know the statistics better than I do know that's an extremely low rate. Here again, the type of hormone, the Endocrine Society said doesn't matter. And here we go with our lying dog-faced pony soldier again. It's just not true. The myth that the Women's Health Initiative saved lives by demonstrating the dangers of hormone replacement therapy. 10 years of randomized treatment, oral estradiol and norethindrone early after menopause significantly reduced the risk of mortality, heart failure, and myocardial infarction, without an apparent increased risk of cancer or stroke or blood clots. Our rule of thumb, never, ever, ever use estrogen without progesterone. And my doctor students that I have, I make them pinky swear. Okay. I cringe when I see somebody come in, even on estradiol and they're estrogen dominant and they're not on progesterone. So we quickly, try to correct that. And believe it or not, Premarin is still available. And every once in a while, a patient will come in taking Premarin. And every once in a while, you need to be a little bit careful because the pharmacists, at least in Nevada, are allowed to substitute. And it happened once, or I think twice since I've been here, and I read them the Riot Act. Usually it's either a young guy right out of school who knows everything, Mike, or an old timer who, hasn't read a book since 1980. And they'll just substitute the Premarin for the natural progesterone or estrogens. So you need to be careful. You need to make sure that the patients are taking what you want them to take. Breast cancer remission for 2 years. Low levels of estradiol are deemed safe. But if you don't want to use them because, we live in the world of litigation, black cohosh and chasteberry work nicely. Siberian rhubarb extract, Swedish sunflowers, which is called Relazin. You used to be able to get samples of that. We can't anymore. You can get it on Amazon. It's a little bit pricey, but they're actually quite effective. They will take care of the estrogen symptoms: hot flashes, night sweats, brain fog, belly fat. You can also get something called Seranol, 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 made by the same company. And Seranol will mimic natural progesterone. And the symptoms there: agitated, irritable, can't sleep, poor libido, headaches, short-tempered. The Endocrine Society suggestions here: gabapentin, clonidine, paroxetine, and citalopram, the SSRIs. Other hormone options might be vaginal DHEA, estradiol, and testosterone to address vaginal dryness, and progesterone to modulate estrogen receptors. Other interventions for estrogen balance: cruciferous vegetables. But remember, you need to be careful with these in patients that have thyroid issues. These are what are known as goitrogens. They will make the thyroid worse. So you need to balance that. Iodine will promote the CYP1A1 enzyme. Flaxseed, high protein diet, exercise, omega-3 fatty acids, and acetylcysteine. Folic acid, B6 and B12 methylated. Soy, you always want organic. We're sort of getting away from that. And isoflavones. Estrogen use in the presence of breast cancer. Like I said, it's not completely contraindicated if in remission for over 2 years. Mammogram and clearance pathways have been evaluated. The clearance pathways we evaluate with the Dutch test and mammogram. And then testosterone for women. It's the most abundant active sex steroid in women throughout the female lifespan. It helps maintain muscle and bone strength, restores sex drive, and improves overall feeling of well-being. It reduces LDL cholesterol. It helps replace and increase bone mass. And testosterone deficiency leads to dry eyes, pale faces, and thinning of the inner 1/3 of the eyebrow. Testosterone's only role in women is, again, a myth, is sex drive and libido. And of course, that's not true either. We've gone through these a number of times. Testosterone will masculinize females. You'd have to use extremely high doses for that to happen. It can cause hoarseness and voice changes. There's actually no evidence of that. And again, you would have to use extremely high doses. It causes hair loss. Actually, testosterone in adequate levels will increase scalp hair. Testosterone will cause hair loss in high doses, or if the testosterone levels are low. Testosterone causes liver damage yes, it does, in oral preparations. Now, there's 2 new FDA-approved oral testosterones. I really haven't looked at them very closely, and I don't know what their effects on the liver. I'm assuming that they must have done something to it. Mike, maybe you know that to temper that. Otherwise, I can't imagine why they would be approved. Because testosterone, oral testosterone is well known to be hepatotoxic.
Mhm. Well, you bring up a good point there, Bill, which is that really the problem with all synthetic or non-endogenous hormones is that their metabolic pathways lead to the production of toxic substances and metabolites that interfere with other processes along the way. So by taking the same hormones that our bodies are designed to utilize, that's the best course of action in that with respect to the production of odd metabolites And I know there's many people with metabolic problems that we have to diagnose and address and all that stuff that fall in, that kind of complicate that. But overall, that's the reason to use bioidenticals, is that the body knows how to handle them.
All right. So you're getting the point here that the bioidenticals, are a friend and the synthetics are not, and the powers that be don't even want to look at it. Okay. We talked about this before. There's more than double the risk of breast cancer without adequate testosterone. DHEA is an anti-aging supplement, is not any good, but it doesn't do any harm. Again, according to the AMA paper, it builds and protects against cortisol catabolism. As I mentioned before, in 1952, it was recognized as an antidepressant. It decreases visceral and subcutaneous fat and improves bone density. It relieves fatigue, dry eyes, and dry skin. It regulates mood, supports the immune system, and improves insulin sensitivity. It's a precursor of testosterone, and it acts as a mini testosterone. So if we want to get the effects of testosterone, but don't want to use testosterone for whatever reason, DHEA comes in pill form. You can get it pretty much anywhere. It's pretty inexpensive. We can use this as one of the building blocks for testosterone. It decreases atherosclerotic plaques. It inhibits platelet aggregation. It inhibits free radical formation. It improves sexual function, skin tone. It reduces vulvar atrophy. Postmenopausal, shows no systemic side effects. Low levels are associated with all-cause mortality, cardiovascular mortality, obesity, and type 2 diabetes, immune dysfunction, autoimmune disease, cancers, hypertension, depression and loss of well-being, low libido, erectile dysfunction, and osteoporosis. This was a study done in 2008 called the DAWN study. It showed that cognitive life satisfaction and sexual function were evaluated, and it showed that increased DHEA levels will increase testosterone levels in women and estrogen levels in women, but not men so much. There were no adverse effects. In 2017, I believe, the FDA approved, and again, I can mention brand names here, Intrarosa, which is an intravaginal DHEA for vaginal dryness, once daily therapy at bedtime, and it demonstrated efficacy, and it was a non-vaginal based therapy. It comes as an insert. It's fairly expensive, and it's indicated for moderate to severe dyspareunia and vulvar and vaginal atrophy due to menopause. 7-keto DHEA, I'm just going to mention this. We measure estrone levels. Estrone sends your patient down the pathway towards cancers. It was touted really in the late 2008, 2009 by Dr. Oz, of all people, on his TV show for weight loss. What it does is it lowers estrone level. So estrone, as you know, holds body fat in. It improves lipids and improves memory in rats. We can use it as part of a weight loss program. 50 to 200 milligrams in the AM. When we measure our estrone levels, any estrone level greater than 100, we will treat the patient with 7-keto DHEA. It works quite quickly. It will decrease, on average, patients' estrone levels by up to 50% within 4 to 6 weeks. There was no long-term cognitive changes in the therapeutic doses of anti-aging hormones. This was the last talking point. And so we can go through, a lot. There's a lot more to go through. Vitamin D, of course, shows infection protection, cardiovascular risk, irritable bowel syndrome, ovarian cancer, dementia, keloids. Melatonin is a free radical scavenger. It delays aging. It's anti-inflammatory, inhibits tumor growth. Telomeres, of course, prevent deterioration due to accelerated aging, and are anti-neoplastic. They can restore organ function. Pregnenolone, estrogen, progesterone, DHEA lessen or prevent psychiatric disorders, including schizophrenia. And I do have in our TBI course a whole lecture on psychiatric disorders and associated with TBIs and hormone disruption. And aldosterone is adequate testosterone will combat both hearing loss, balance, and tinnitus. This chart will give you, went through all of the symptoms, and when the hormone levels are increased or decreased, we will end up with these types of symptoms. So if you're new to this, this is something you can keep by your desk. So if you run into problems, you can kind of glance at it quickly. And so these are all the talking points. And so do you agree or disagree with the AMA or what we presented here? Current evidence does or does not support the use of testosterone in older men with low testosterone levels. Evidence of the value of testosterone as an anti-aging therapy does or does not exist. The long-term use of estrogens with or without progestins causes more or less risks than benefits. And remember, progestins is not progesterone. The long-term use of estrogen for the prevention of chronic conditions in postmenopausal women is or is not warranted. Current evidence supports or fails to support the evidence of HGH as an anti-aging therapy. DHEA as an anti-aging supplement shows neither a meaningful benefit nor serious adverse effects. And there is or is no evidence for long-term changes with the use of anti-aging hormones. In this report, we have 133 non-credible evidence published studies from journals, including a multitude of mainstream medical journals. These are new FDA-approved bioidentical hormones. I already mentioned the first one, the Bijuva. The second one I mentioned, that's Intra-Rosa, the DHEA vaginal insert. Bremlomide, which is PT141, which is a peptide for sexual dysfunction, is a peptide. It's called Vyleesi, is the trade name. We could get it from compounding pharmacy or those who supply peptides for $50 to $100, usually a bottle, somewhere in that range. Vyleesi is now $709. It may be $899 for a month's dose. And of course, there's the so these are our sorry, I misspoke. The DHEA vaginal insert is at the bottom that I mentioned before, Intra-Rosa. There's an estradiol vaginal insert also called Imvexi, it's called. That's an estrogen insert. So we visited with the folks with the PhDs after their names. We think we've given you plenty of evidence to support our position. Lucy and I, this was Lucy in 1921, believe it or not. Thank you. I have sponsored through the American Osteopathic Society of Rheumatic Diseases, if you're interested, a 10 credit for AMA and AOA a CME credit video course. It's 7 hours. There's an extra hour that we've added, but it's not been approved yet for CME credits on the laboratory of bioidentical hormones. And this lecture that you got was lecture 1. We go through the steroidogenic pathway. We go through the male hormone primer, female hormone primer. We do the thyroid show. We do low dose naltrexone, and then the last lecture is 2 hours. We put it all together so that you can have a roadmap. We have charts. We have treatment protocols. It's fairly complete. It's not the advanced stuff, but it's good enough to get you started. If anybody's interested, please contact me. Dr. Halassa, we'll go through the chats, but I have a request from, if I can ask your audience. I was informed last Thursday that coming up in 2 weeks, the AOA's House of Delegates is going to vote on whether to decommission our group, the American Osteopathic Society of Rheumatic Diseases. The reason they're giving is because last year we applied for a change in our charter to integrative medicine. And apparently that did not go over well with them. They told us no at the time and we dropped it, and I didn't hear anything about it till last week. If any of you here have benefited from myself, if you've been to our classes, if you've been to our Tuesday night classes, if you could write us a little testimonial, I would really appreciate it. I wasn't going to go, but it looks like I'm going to have to go to Chicago to plead our case. We went from 4 years ago, they handed me a checkbook with $800 in it. We are a thriving organization, and the fact that they want to try and we not just 2 months ago, we just were recredentialed for 5 years, which is the highest recredentialing that they give to anybody. We were credentialed by the AMA. And now they've turned around and decided that they want to throw us out. So if anybody can just take 5 minutes, here's my email address. I need some testimonials. If what we do has been worthwhile to you, I would really appreciate it. And then I'll get off my soapbox now. So where do you want to go from here, Dr. Halasso? There's 41 chats.
Well, we will go through the chat, but let me make sure that it's all politics, whatever they're doing right now. I think there's someone in the other side has jealousy or hates you, and he's trying to react to that. So I think the best approach is getting into the higher ranked people and get politics and try to come to fight it.
Well, the really disappointing part of all of this is that the incoming president of the American Osteopathic Association is a fellow named Ernie Gelb. Ernie and I were partners, literally partners for years, for 15 years. When Ernie's office, where we lived, there's a flood area. Ernie's office got flooded out, and I had him in my office. I shared my office with him for free for a whole year. And now he's the incoming president of the AOA. He told me that he recused himself from this controversy and he had no opinion of it, but it's pretty disappointing. So I'll leave it at that.
Yeah. Well, no matter what, Bill, you're always welcome with us. And if you want to move the Academy of Oxidative Stress Disorders, we'll make that happen.
Well, we are a CME, accredited organization, for another 2 weeks anyway. And I'll give you a dirty little secret, which, I've been keeping under my hat. I've actually been negotiating with A4M to be their CME provider. So they throw us
one
out.
of the A4M, Amy, I think she was an A4M director. She was here attending it to witness what you have. So I think she will be impressed, and I think the A4M will be glad to have you.
Well, we talked to Dr. Klatz last week, and Dr. Klatz and Goldman were DOs, and they started that 20 years ago, and the AOA told them to go get lost then. And
That's right.
But it's politics there. It's all politics. And I think you need to deal with it and the high ranked relationship versus the bottom. And we can go ahead and I think everybody here will write a letter. Yeah. But it's more about how you can reach to those people who are having the key.
Right. Okay, let's do the chats.
Yeah. All right. Let me moderate. Guys, let me moderate the chats, okay? Let's see. Let me go. One thing, just on the subject, guys. Bill, if you don't mind, maybe letting us know specifically where to send these letters. That's been a question that came up. Like, if you would like some responses or someone to write a letter, where would you like them to send that?
Actually, if you could send it to them, I have to get you the address of the president of the AOA, but just send it to me, okay? Dr. Bill 9. Where's my here? How about Dr. Right Bill?
He'll post his chat. Yeah, he'll post his chat.
It's right here.
Okay.
Dr. Bill 9 at Gmail.
All right. So if you want to support Dr. Clearfield in his endeavor to work with the DOs, please do that at that address. Okay. How can we watch this again? The answer to that is we're trying to come up with a better way to do that. Right now, just contact me or Dr. Halasso, and we'll give you a link to it. Let's see. We had a question about, one question that kind of came up was, maybe Bill, if you could talk for just a minute about the pharmaceutical interventions like the bioidentical hormones versus the naturopathic, interventions such as the herbs and the various different things. When is it appropriate to use one or the other, and what's your feelings about that?
Well, I'm a medical doctor, so I go more towards the bioidentical, compounded hormones versus the natural hormones. However, I will say this: there's a lot of times for whatever reason we don't want to use those hormones, and we're pretty well schooled on a fair list of supplements and and natural remedies for things like hot flashes, night sweats, low testosterone, and we'll use different combinations. You know,
Gotcha.
there's lots of companies that make a bunch of combinations that work quite nicely. For instance, for instance, there's an Ayurvedic herb called Shilajit, there in the and again, I'm not promoting anyone, but the one I'm familiar with is Testoplex from Zymogen, has that in there, and that works quite nicely.
And do you see levels come up correspondingly, or is it
We
just
do,
symptomatic?
we do. Not as predictable as using like bioidentical testosterone, but you will see blood levels come up. Okay.
Okay.
And the patients will feel it too. You know, the patients will tell you, you know, if they feel better or not. That's usually, you know, sort of your first clue.
Okay. Here's another question. Now, you mentioned that breast density is a sign of estrogen dominance, which makes a lot of sense. Now, if this is a problem for a patient, would treatment with progesterone result probably in improvement? And if so, like, would that take a long time, or would that be a fairly rapid improvement?
Probably, depending on how you do it. What we like to do is, this is where we love using the progesterone creams. You know, we use 1 gram at bedtime. We have the patients put it right on their breastbone, split the dose in half, rub it into both breasts, or if they have a lump or you know, a tenderness on one side, we can rub it into both onto the one side, and you will find it'll take about 4 to 6 weeks. They'll start to soften up, and most times 3 to 4 months, the fibrocystic tissue and the breast, you know, tenderness and breast cysts are not 100% absent, but almost nearly gone.
Okay,
So-
that's great. So would you recommend also systemic therapy to support that, or do you think just the topical therapy and localized therapy is
Usually, I'll pick one or the other. If the patients are still cycling, we usually will start with the creams, and I'll start with over-the-counter creams, a 5% cream, or you can get a 7.5%. I think you can get over-the-counter also. If it's just a little bit of a sleep problem, we'll use a 2%, especially if their lab values are looking like, you know, a little bit more estrogen than progesterone. If it's a long-standing issue, if the estrogen dominance is quite severe, then we'll go right to the oral agents. The oral agents are more potent than the creams in the progesterone world. So we'll go with the oral agents. We don't have the issue with the progesterone going through the liver and causing all sorts of havoc that you do with estrogen.
Okay, very good. Okay, here's a couple of other questions that we have in the chat. On DHEA, I think I know the answer to this one, but do you tend to like oral supplementation or topical?
I usually go with the oral. It's easy, it's cheap.
Yeah, it's so cheap.
You know, yeah, you know, so I mean, you can get it at the dollar store. Not that I would recommend it, but I mean, you can get it pretty much anywhere. It doesn't cost a whole lot. So, and then sometimes some companies, one company we use, Douglas, I think, makes a DHEA pregnenolone combination. So I think
it's the precursors all in one pill. Yeah.
Would DHAL will not metabolize in the liver or something like that? Maybe topical is better. Is that what you think, or it's no?
I've not had any problem really, you know, with the precursors.
Yeah, we want it to be metabolized, right?
Yeah, yeah. These have to be metabolized. These break down into the hormones, so that's what you want.
Now, there was a question as we discussed things like estradiol and estrone and all these things being bioidentical. There was a general question just about, is all compounded testosterone, or all really any testosterone, it is all bioidentical? My understanding of that is that yes, but is your
No.
you have a
No, you get your commercial products, you know, Androgel, Testim. I forget what the name of the one is. It's an underarm deodorant. Those are all those are all altered. They are not bioidentical. They are they are drugs. Okay, they're made that way so that you have your own unique, you know, patented
right.
But as you
that's
know,
why they basically why they can't do that's why they kind of the pharmaceutical companies don't really want to do the natural hormones, because their public domain, so to speak,
Right.
as they should be, right? Okay. What about now? Here's a real general question, but I think this is an important question. At what age do you see with a menopausal female? Is there any age limit that you feel at some certain age you don't treat patients because they're too elderly or et cetera?
The answer is I have a couple of, I've had a couple, not many, but I have a couple women in their 90s. I'm careful with it. We use very tiny doses. I usually only use testosterone in very small doses, like 5 milligrams per week, which is almost nothing, but we do get some response to that. It's usually more for strength and energy and sort of mood. If you listen to the powers that be, you're only supposed to use these hormones and the synthetic hormones that they recommend for the 10 years after menopause, and then you're not supposed to use them. But when they wear off, I mean, it's as you didn't use them at all. We're careful with them. We let our patients know, what to expect. We tell them if there's anything untoward going on to let us know. But like I said, I've had 2 patients in 20 years develop a breast cancer with taking bioidentical hormones, which is a pretty damn good track record, if you want to know.
Very good. That's right. Well, that kind of completes the questions that we had in the chat. So obviously, it's really, Bill, I really appreciate you coming and doing this lecture for us, because just like a great movie or a great piece of music, every time you hear these topics, you learn something new, and it doesn't matter how long you've been doing it, you'll learn something new, a little tidbit here or there. And that's really the beauty of what we do here. So thank you so much for that. Now, does anyone else have any questions that they'd like to bring forward for?
Yeah, let me add something here, just because of things I'm trying to link the dots here. One of the things that we know about polycystic ovarian disease, that they have high prolactin, and that's the problem. They don't have the problem with fertility, because I think it inhibits the 6 hormones, the high prolactin.
Mm-hmm.
And we find out just recently from those publications, I was digging through it, and especially with, I have very passionate with McCarran Blvd, and McCarran Blvd does have anti-dopaminergic effect. So it's being used for schizophrenia, and it's being used for bipolar. And also it's being used to decrease the prolactin production. So I would like to see, in addition to giving anti-dopaminergic drugs for patients with polycystic ovarian disease, why we don't just try to add McCarran Blvd in the equation, because McCarran Blvd does have the anti-dopaminergic and has less side effects than the anti-dopaminergic drugs, and see if we can come up with some results, in addition to increasing the serotonin and helps in depression. So something I may see if this is something people here or doctors here are interested in finding out if this will help their patients with polycystic ovarian disease and help in their fertility.
Works for me.
Well, reducing oxidative stress is going to improve receptor sensitivity, right?
Right.
Yeah, but this is direct decrease in prolactin production, and the only thing that we have in the market is anti-dopaminergic drug, right? And so if McCarran Blvd can do that, it can definitely help, because all those anti-dopaminergic drugs that we're using for managing polycystic ovarian disease, they have side effects, and very bad side effects. So if we can replace it with McCarran Blvd and see if this would help to decrease the prolactin, and that's why I'm trying to say, if you have polycystic ovarian disease, and I think everybody has patients with polycystic ovarian disease, can we use McCarran Blvd in the state of the prolactin? I think they use progesterone as well, right? Because it's estrogenic dominant, or what, Dr. Bill, polycystic ovarian disease, they have too much of testosterone and estrogen, right?
Right.
And so do they give them progesterone as well for treating polycystic ovarian disease, or
Yes.
what is your take on that?
Yes.
Okay, so if we do progesterone
I mean,
and Metlam Blue,
in general, it depends on how, what their, how their cycle is.
so basically you do the lab and you find out what they have of their sex hormone high, and then you
Right.
start giving the treatment. So if they have low progesterone, you will start giving progesterone, and then you're giving antidopaminergic drugs. So if we
Right,
can
and-
replace that with Metlam Blue and see if this will reduce the prolactin, because some of antidopaminergic drugs have failed to decrease prolactin and really fail in fertility. Can we help them with Metlam Blue? I need some. There is publications already. I did post it in the website and in the chat. But I want to see if this can happen. And if this happen, this is going to be a very breakthrough kind of treatment because there's a lot of failure in managing polycystic ovarian disease.
I don't disagree, but I should mention one point here about methylene blue is that, and I don't think pregnancy is the issue here, but it is pregnancy category X.
Yeah, maybe when you start having the pregnancy, you may discontinue it and continue with progesterone, other drugs. But at least if you can lower the prolactin and increasing the fertility there, and if she become fertile, then possibly. But my question is that can we reduce the prolactin, even for guys who have gynecomastia and they have big boobs and all that? They must sometimes they have too much of prolactin. Is this what help them? So can we find out, and can you help us to get some data out of that so we can publish it? Because this will be kind of breakthrough. There is publications about it, but we need to, as a group, to come up with our results and present it and see if this is something it's factual and clinical.
I think
did you come up with any dose when you were reviewing the literature?
I think it's 15 milligram per kg, 15 milligram daily. But you can look at those. I will share with you and look. I just went through it very fast. I found 3 articles about it. But I did post it there. But me and you, we can chat together about
What was the dose? 60 milligram?
15 milligram daily, I think.
What? 15?
That's 15, 1-5.
1.5 milligram daily. But I will just more dig into and find out exactly how much it is, and you can help me with that. And then we can come up with something about this, especially the guys. If you consider about females, they may have problem with their pregnancy, effect of Metlam Blue against pregnancy, but can we see for the guys? Because the guys also, they have problem with prolactin high. A lot of them.
When young girls, meaning 16 and 18, many times they have a lot of hair and thick hair. So then they go for hair removal. And now at least the hair removal, the staff knows that those are the patients. They would tell them to get them checked for PCOS. And many of them, they have PCOS. And the high amount of testosterone and prolactin is high, but not very, very high as compared to the testosterone. So I don't know what is Dr. Bill's experience.
What was the question again?
Question was that in your patients with PCOS, the young girls who are 16, 18, 20,
Right.
and they have a really, aesthetically very hairy and thick hair on the body. So when you do evaluate them for PCOS, what have you find them more? Because testosterone is really high, but prolactin, how high have you found?
Prolactin levels are usually moderate.
Yeah,
Testosterone levels are high, blood sugar abnormalities, and usually irregular periods. That's your syndrome. Downstream.
But the treatment, when they treat them, they give them antidopaminergic drugs, right?
Yeah. Downstream, you're going to have high estrogen because of the high testosterone. So you need to deal with that issue also. The medical doctor medications are spironolactone, which does work nicely, blocking the side effects of testosterone, acne, oily skin, hair, excess hair with that, and it'll lower testosterone slightly. Metformin is the other drug that's used. It's sort of the drug of choice that's used, especially for will also lower testosterone slightly, but will also improve your blood sugar panel. And here's where we use a lot of supplements and herbal remedies. So, for example, spearmint tea, 100 milligrams a day for about 4 weeks will decrease testosterone levels by up to 23%. So 100 milligrams of spearmint tea, if you get Lipton tea, which is there's 70 in a bag, you do 2 bags and 1 cup of water a day for 4 weeks, you can decrease the testosterone levels by up to 23%. Deglycerinated licorice we like to use, especially if they have a GERD or hiatal hernia or heartburn, will also lower testosterone levels by up to 12 to 15%. Omega-3 fatty acids by up to 7%, 2,000 milligrams a day. N-acetylcysteine, 1,800 milligrams a day, will lower testosterone levels by about 12%. So you put a few of those together and you've got yourself a pretty good regimen. You also have an oxidation regimen. You have an anti-inflammatory regimen, and you'll get a reduction in the testosterone. For blood sugars, we can use things, we like berberine, and we'll use cinnamon or cinnamon derivatives. Gymnea sylvestre is another one. Vanadium is another one that we'll use to lower insulin and reduce insulin resistance. And again, you have your metformin, and if you need to use medications, we're going now more towards these incretins. The newer ones have a high weight loss component that goes along with them. So semaglutide and tirpazidine is the latest kid on the block. The problem with them is they're very expensive, and the pharmaceutical brands, there's a high incidence of nausea with discontinuation. So that's a sort of a good way to go. Inositol, it tempers the irregular periods and heavy periods, and that's something that we use quite frequently.
How much inositol would you use?
I use a brand called Ovasitol, and it comes as a scoop. And quite frankly, off the top of my head, I can't remember what the doses are. 1 scoop a day in water. It's called Ovasitol, and it has the 2 isomers of inositol in it. It's also somewhat sedating, so it'll help them sleep also.
So they also give them the bromocriptine, I think 1 milligram daily, bromocriptine, which is anticholinergic drug.
Yeah, that's if the prolactin levels are high or they have pituitary adenoma.
So they give that. Again, they can give berberine instead. Metformin, you can give it as well, but berberine can be a replacement as well. High dose berberine.
Yeah, we use
another treatment.
We use a lot of berberine. A lot of the polycystic ovary patients do not like metformin. They'll come in and say, usually by the time they get to me, they've been to 3 or 4 other places and they've had it for years. And the first thing they say is, if you're going to give me metformin, I'm walking out the door. So
so you give them berberine.
I hear that over and over again. That's pretty common. So
and they have a hair loss. So the female and the hair loss, it just doesn't go together.
It's androgenic because of testosterone. Too much of it, you would have this kind of androgenic loss of hair.
Metformin,
so they have growth hairs on their face, and they have baldness like male because of the high testosterone. And it has to do with the hair follicles. Are when you have high testosterone, whether it's female or male, they end up.
It's DHT, guys. It's DHT.
Right? Is that right, Dr.
Yeah,
Mike?
it's dihydrotestosterone.
Yeah,
so it's toxic to the hair follicle.
Remember, testosterone converts to dihydrotestosterone, which is toxic to head hair follicles. But
exactly.
But below the eyebrows, the testosterone will increase hair growth.
That's right.
Because there are anti-inflammatory agents in the skin that will neutralize the conversion from testosterone to dihydrotestosterone.
Hey, Bill, why did the patients not like the metformin, if you don't mind my asking?
I don't know. There are a lot of GI upset. I probably going to get blood sugar drops.
Yep.
You know, not any one thing, but it's fairly common that they just
They just don't feel well.
Yeah, they don't feel well.
Okay. Well, very good. Any other questions? This is fascinating. Great conversation. Anybody got something else to add to the pie here? The punch bowl.
So just to let you know, tomorrow night we have Dr. Halassa talking about, well, you guys already heard this on the Hashimoto's thyroiditis, right? So this group already heard it, but if you want to hear a replay, our group is doing it. So
well, and the discussion's always different, guys. You know, a group of different doctors will be there and they'll ask different questions, and you know, you'll see the same slides, but you'll hear different discussion too.
Yeah, we will try to make it as entertainment, especially with Dr. William Bill. He's very good in keeping the vibe. And
yeah, I last week when you did it, I threw my 2 cents in, and I hope it was okay.
No. In fact, I like those things because that's how we are engaging and that's how we are entertaining, is really to add more. Like, for example, I'm asking everybody to see if we can decrease prolactin with McCarran Blvd because there's publication there, but we needed to see in a clinical. So if there's any other things that we can suggest, and from here, do you have any ideas, any new ideas, anything that we can flavor, spice the whole conversation from all the audience here? That would be nice, because I'm that's what makes the whole event and the whole conference fun and attractive.
Okay, I got somebody asking me what the link is for tomorrow night. So can you hold on before you sign off, Dr. Halassa? Let me find it.
Yeah, and while Bill's looking for that, guys, don't forget, really one of the most important things as a housekeeping item that we talked about tonight is that we need to help Dr. Clearfield with his situation with the board of osteopathy, right? So if we support that, that would be really great.
Yeah, and let me add other important thing that we learned from Dr. Bill today is that natural product that's coming from the nature are more compatible to the body. I mean, our body's being engineered with the enzymes to deal with natural products. But when we have the man-made products, then the body cannot really recycle it, and they end up developing toxins and metabolites, or hard to get rid from it. So they have constant effect, which can lead to all this adverse effect. And I think that's the difference between a natural sex hormone, which is coming from soya beans, right? Which we eat, just they extract it in high concentration. Same thing they do with CBD. They extract it from the marijuana plants. It's the same concept. This is just more of concentration of the extract of the plants. But I don't think we have any natural testosterone. But here's my question, Dr. Mike Beamer, to you. If we test this from the cows and we dry them, and can we extract testosterone from it, and can we consider that as natural for us or no?
There's a couple of issues with that. I mean, if you could cleanly do it, if you could magically do that with no traces of other things, then theoretically that's true. But that tends to be the problem, right? Because you always get other similar agents and metabolites in with the non-human source. So whether that's insulin or whether that's testosterone or hormones or thyroid, they're not probably identical as products, even though they can theoretically be the same active ingredient. It's that you're getting other things that are inevitable that you can't eliminate. And I think that's part of the problem there. You have a certain, and when we look at a certificate of analysis, we can see that, because the FDA and the manufacturers that make these things, they know all the metabolites. They're required to know that, and they actually are required to test for certain ones that are considered to be problematic potentially. So you can actually find that if you get a very complete, high quality certificate of analysis, like you would get from somebody like what the Israeli company there's an Israeli company that makes a lot of API, and they have great C of A's. If you get one from India, you don't get a C of A like that because their country doesn't require it. So it really depends on how it's extracted. But I think theoretically the answer is yes, but practically the answer is no.
Yeah, I can speak to that too. The Chinese for millennia have had products like 3-penis pill, which is supposed to increase testosterone. And it's a precursor, and I do think it does, and it actually does have testes from various animals. Also, deer antler has been around for a long time. Of what a lot of farms now in the state of Washington, for example, they have elk, and they shave what happens is when the deer or the elk is in rut and he sees the girl, then all the testosterone goes up to the horns, and they sacrifice the horns without killing the animal and take the velvet. I've experimented with all of it, and I can't get consistent and high enough levels on men or women. And for that matter, natural products are great. As an herbalist, a doctor of Chinese medicine as well, I can tell you, I like to go that route, but if you're going to have a side effect, herbs can cause many side effects in patients that are sensitive. So then I move, actually, the creams, Dr. Halasa, the bioidentical creams are very gentle, I find, and you can use really low doses and just apply it vaginally versus, a lot on the wrists and so forth for sensitive types of people. But to that, I did want to mention Dr. Bill's excellent lecture that for all patients that I have, men and women who are hormonal, which means their entire life, I always give them something for their liver to help the conjugation, phase 1, phase 2, to conjugate any drugs they're taking. So if you have an acupuncturist, get a nice, or an Ayurvedic person, more likely an acupuncturist, you get something for your liver, which would be better than a one-shot deal like alpha lipoic acid or milk thistle. They're okay, but a formula would be better. Okay, I'm done.
Very good. Very good. All right. But I think I agree with all of that. Okay. Well, anybody else got anything before we go? And if not, everybody, thank you for being here tonight and listening to Dr. Clearfield's lecture. And don't forget to give him a helping hand where you can, and maybe even stop by there tomorrow night and see what's going on with the Hashimoto's again. So thank you, everybody. And thank you, Dr. Bill, for your presentation.
Thank you all.
Thank you, Dr. Bell.
And
Great job.
Here's the link. Here's the link for tomorrow night, by the way.
Yeah, it's in the chat. I'll leave I won't turn the meet. Well, Halasa won't turn the meeting off. But as we check out, if you want to stay just a brief minute longer as people log out. Thank you for coming tonight, and you can look in there for that link to send a letter in support of Dr. Bill's work.
Yeah, that's at drbill9@gmail. I appreciate it more than you all know. So
you bet.
Okay.
Thanks.
Good night.
Right.
Bill.
Thank you. Thank you all. Good night.
Bye.
Okay. Bye.